I will begin with my presentation, sir. So whenever we go to any retina conference, we all know that we do talk about the dying art of scleral buckling, and we also know that PPV is not the answer in all the cases. So what if we could combine all the advantages of buckling and still, get and could mitigate all the disadvantages of buckling? So I will be presenting my early surgical experience of suprachoroidal buckling. I'm not an expert in the field. I'm still in the learning phase, and I've been doing it for the last 6 months. So I don't have any financial stress. We do know that suprachoroidal space is a potential space between the choroid and the sclera, and it is almost 30 micron. It is transferred by the ciliary nerves and the vortex veins. And this was a video presented in ASRS 2014, which was won the best Red Buckler Best of Video Awards by Flavio and colleagues, and in which they beautifully showed how beautifully the ciliary nerves spark transverse and the vortex vein transverse, and this is the potential space that is just between the choroid and the sclera. It has been used, suprachoroidal space is being potentially investigated for a lot of cases like buckling or drug delivery or stem cell and gene therapy and access route to a subretinal space. And today focusing on my talk would be on suprachoroidal buckling in peripheral retinal detachments, and this is my surgical experience that what I'm talking about. It has been described in literature by Ahab and colleagues in 2013, and then what they made is they made a modification of the initially it was a traumatic it used to cause trauma to the choroid, so they made a special olive tipped cannula which was not traumatic, and you can transverse the suprachoroidal space. They also published a literature of 41 eyes in which they did suprachoroidal buckling with Helon 5 in 41 eyes, in which they had a success rate of around 92% in a primary case. So I also started experimenting and started learning this art of suprachoroidal buckling. And my first case was a very, very safe case. I wanted to do in a case which was already done a PPV with, and then I wanted to see how it's all done. In this eye is already silicone oil infused eye, and then I have made an access route to the suprachoroidal space, and I am passing the olive tipped cannula. Now what is important in this case that I have already, when you see on the inferior, there is already an inferior dome that has already been created. So this was my first case, and I have created a wrong dome, and I am again secondly, if you look on the left side of the screen, I am trying to create another dome which would lie on the, my first experience was that while doing ciliary illumination, it is actually difficult to visualize where your cannula is and where your indentation is being done. So this was my first learning curve. So visualization is the key when you are drawing the suprachoroidal buckling. What was another thing that I noted was Helon as a suprachoroidal filler lasts only for 2 weeks. And what if I wanted to indent the inferior 180 degree of retina? I wanted a prolonged indentation or myopic traction maculopathies. So I wanted to shift to a long-term filler. And we all know dermal fillers have a long life, around 12 months. And they also induce a permanent choroidal separation. So that is the one thing that we can use. They are used for lip and nose jobs that are being done. So currently 2 fillers are being in market. The one is the Retinal and the one is the Juvederm. But they were very expensive. For 1 ml it costs around 20,000 rupees. So I had to, like the place where I practice, it was not practical to have a 20,000 rupees 1 ml filler. So I started my experience with a new doctor filler which is available in Korea made, and it is around 2,000 rupees, which was compatible with my clinical practice. Till now I have done 7 eyes. I presented in VSI, it was 6 eyes. Now I have one more eye of primary scleral buckling, which is 7 eyes. So 4 eyes are PPV with suprachoroidal buckling, and 3 eyes are of primary buckling with suprachoroidal buckling, and the filler used is doctor filler. So this is a case in which I am doing a 180 degree inferior buckling with suprachoroidal buckle. And what I have done is I have made a suprachoroidal SSS at the 6 o'clock position. This was also a case in which there was a macular hole as well as inferior PVR. So now I pass the suprachoroidal olive tip cannula either from the 3 o'clock hours on the either side or from the 6 o'clock meridian. And I asked my assistant to gradually push the filler, and what you can notice in that I've got a beautiful 180 degree inferior indentation in the inferior retina. So this was used mainly for indenting the inferior retina in combination. This was a 1 week post-op when the macular hole is closed, and we can still see the buckling, although not that clear because of the silicone oil. This was a case of primary scleral buckling, and this was done just few days back. And in this case, this was a post-traumatic RD with 2 superiotemporal holes post-traumatic. So first of all, we do the ciliary illumination, and then we indent the choroid, and then we cryo the breaks. And once we are clear where our breaks is, we go outside, and then we mark the brakes externally. So when we are clear where our exact brakes are, and then we again proceed with doing further cryo around the brake, so that we, after the healing process, we get a good chorioretinal scar. So we do the mode of cryo, and we all know the advantage of Sandler illumination scleral buckling is that you can go and actually look for any other further breaks. So we look for any more peripheral breaks, and once we are clear, then in the radiant meridian in which you have done the mark the break, you create a suprachoroidal access route 4 mm from the limbus, and once you have created it, you do a partial SRF drainage, so that you can create a space for the filler to be accommodated in the eye, and then you pass the olive tip cannula radially towards the brake. And now this is the difficult time, because this is the point where you note where your tip is actually. So if you look at the top right corner, you can see there is some activity. So that
Your time is over.
okay. So this is the so basically, the reattachment rate was 7 on all guys, and the doctor filler is biocompatible, doesn't have any vitritis or sclerochoroidal inflammation. The amount of indentation lasts around 12 weeks. So we can get away with all the disadvantages with suprachoroidal buckling, and only the cons is it has a very high learning curve and a long-term indentation. We have to look into it. So thank you, sir.